Hello, everybody. This is the April 2026 Heart Rhythm O2 podcast. I'm Jeanne E. Poole, the editor-in-chief. Thanks for listening in today. This is a pretty full issue. I'll be reading the title of the paper, the first author, and the key findings. The first paper is titled Single or Multiple Pulse Field Applications, Intracardiac Electrogram Changes and Implications for Procedural Endpoints by Dr. Benson, Schlageter, and colleagues. The first key finding is that immediately after ablation, no difference in electrogram characteristics between single, double, or quadruple pulse field ablation applications was observed. Second, over a 60-second waiting period, only the quadruple PFA applications resulted in lasting lesion effects. And third, the specific electrogram thresholds of the signal power above 125 Hz of equal to or less than 2.5 microvoltage or bipolar voltage amplitude of equal to or less than 0.28 were identified as potential electrophysiologic markers for confirming effective pulmonary vein isolation. The title of the next paper is Same-Day Discharge Can Be Performed Safely After Atrial Fibrillation Catheter Ablation Using a Wide Footprint Lattice Tip Dual Energy System by Dr. Tyler Tagan and colleagues. First key finding is that same-day discharge, according to local standard of care, resulted in comparable days to discharge and acute safety outcomes between patients treated with the novel dual energy lattice tip dual energy system and a conventional contact force radiofrequency ablation system in the randomized Sphere persistent atrial fibrillation trial. Second, shorter procedures ending earlier in the day in white race were more likely to result in same-day discharge. Third, neither discharge date nor the ablation technology used predicted the all-cause 30-day readmission rate or 30-day procedure or device-related serious adverse event rate. And finally, these data support the continuing usage of well-established local same-day discharge protocols with this novel mapping and ablation system. The title of the next paper is Serial or Minimal Fluoroscopy versus Conventional Fluoroscopy in Catheter Ablation of Supraventricular Tachycardias, an updated systematic review and meta-analysis by Dr. Jeanne E. and colleagues. The first key finding is that in this meta-analysis of 11,635 patients, zero or minimal fluoroscopy catheter ablation for supraventricular tachycardia demonstrated equivalent acute success rate with a risk ratio of 1 and marginal improvement in long-term success rates compared with conventional fluoroscopy. Next, zero fluoroscopy or minimal fluoroscopy approaches markedly reduced radiation exposure with substantial decreases in fluoroscopic time, with a mean difference of 13.75 minutes, and dose area product without a significant increase in procedural complications. Third and final, although zero and minimal fluoroscopy was associated with a modestly longer procedure time of 4.47 minutes, this is outweighed by the significant benefit of minimizing ionizing radiation risks for both patients and healthcare staff. The title of the next paper is Sex-Specific Impact of Body Mass Index on Recurrence of Atrial Fibrillation After Catheter Ablation by Dr. Sebher Ozkan and colleagues. The first key finding is that their study showed significant sex-specific differences in long-term outcome of patients with symptomatic atrial fibrillation who underwent de novo pulmonary vein isolation. Second, body mass index and associated atrial conduction indices have a critical impact on atrial fibrillation recurrence after radiofrequency catheter ablation, and thereby mediate sex-specific differences. Third, female sex was associated with a higher risk of atrial fibrillation recurrence after pulmonary vein isolation, as well as post-procedural atrial flutter. Fourth, women with high BMI and prolonged left atrial conduction indices had the highest rate of recurrence after ablation, highlights the importance of weight management in atrial fibrillation. And finally, all-cause mortality was similar in both sexes regardless of BMI category or atrial fibrillation recurrence. Next up is a paper that has the title Acute Hemodynamic Effects of a Novel Algorithm for cardiac resynchronization therapy optimization results from the BioAdapt study by Dr. Francisco Javier Garcia Fernandez and colleagues. The first key finding is that cardiac resynchronization therapy auto-adapt algorithm provides atrioventricular delay and acute hemodynamic outcomes, aortic velocity time interval, left ventricular ejection fraction, and QRS width, similar to those achieved by echocardiography-guided AV delay optimization. The excellent agreement between these two CRT optimization methods is demonstrated by high concordance correlation coefficients for the aortic velocity time interval, 0.96, and left ventricular ejection fraction, 0.93. Both auto-adapt and echo-guided CRT optimization result in significantly better hemodynamic outcomes than standard AV delay programming. Next, considerable interpatient variability was observed in optimized AV delays with both CRT optimization methods, underscoring the value of individualized device programming. And finally, the CRT auto-adapt algorithm offers a practical, automated alternative to time-consuming in-office echocardiography-guided optimization, one-time or repetitive, potentially enabling continuous adaptation to patient needs in real-world clinical settings. The title of the next paper is Safety, Performance, and Remote Programming, Utilization of an Insertable Cardiac Monitor, the LUX-DX Perform study by Mark Richards and colleagues. The first key finding is that the LUX-DX Insertable Cardiac Monitor is a subcutaneous remotely programmable arrhythmia monitoring device with unique algorithms for the detection of atrial fibrillation, atrial tachycardia, bradycardia pause, and tachycardia. Second, in a prospective observational study in a population with multiple indications for ICM monitoring, the LUX-DX was safely implanted in both hospital and clinic settings, and remote programming was frequently used to adjust device settings. The ICM demonstrated strong arrhythmia detection performance relative to a third-party Holter patch, and in fact detected many atrial fibrillation episodes that were missed by the patch. Finally, detection by the arrhythmia algorithms was markedly affected by device settings, arrhythmia prevalence, and episode durations, highlighting the importance of initial device programming and the utility of remote programming to further tailor detection performance. Next up is a paper that is titled How to Isolate the Superior Vena Cava Using Balloon and Basket Pulse Field Ablation System, Standardized Workflow and Initial Results by Dr. Roland Tiltz and colleagues. The first key finding is a standardized workflow using the balloon and basket pulse field ablation system enabled acute superior vena cava isolation in all patients undergoing de novo atrial fibrillation ablation. Second, the balloon and basket pulse field ablation system isolation strategy showed a favorable acute safety profile with no phrenic nerve palsy or major procedural complications. One transient sinus node arrest resolved without sequelae. And third and final, the stable balloon-based wall contact and simultaneous mapping allowed efficient and reproducible SVC isolation with a limited number of applications and short procedural time, supporting the feasibility of this approach. The next paper is titled Spatial Temporal Heterogeneity of Activation Alternans in Cardiomyopathy, Implications for Risk Stratification with Microvolt QRS Alternans by Dr. Nathan Denham and colleagues. The first key finding is that activation alternans is highly prevalent in patients with cardiomyopathy, displays substantial spatiotemporal heterogeneity, and is rate-dependent, where greater activation alternans is observed at faster heart rates. Second, activation alternans sites correspond with areas of low-voltage myocardium, and therefore the microvolt QRS alternans is a non-invasive measure of ventricular substrate. Third, both the magnitude and number of activation alternans sites correlate with the magnitude of microvolt QRSA. Finally, patients with activation alternans at resting heart rates are more likely to have future ventricular arrhythmias. The next paper's title is Obesity Promotes Atrial Fat Deposition Independent of Myocardial Infarction in Gertagen Mini Pigs by Joost Danisbo and colleagues. First key finding is that obesity is the main driver of atrial adipose expansion. Second, obese animals have a higher amount of intramyocardial fat than lean animals. Third, atrial fibrosis is not affected by either obesity or myocardial infarction. And fourth, obesity and myocardial infarction potentially induce adipogenic remodeling through the hyperplasia and hypertrophy, respectively. I'm going to read the conclusion because this is an animal study, and this helps relate the findings to future human studies. So the conclusion states, this study suggests that MI and obesity induce distinct types of adipose tissue expansion in the atria. MI primarily leads to hyperplasia, whereas obesity mainly leads to hypertrophy. This distinction in the mechanism of adipose tissue expansion, particularly in the context of combined MI and obesity, represents a novel contribution to the understanding of atrial remodeling and its potential role in subsequent AF development seen in many patients after MI. In terms of AF substrate, the authors state that they observed the largest expansion in RAA and RA, but it remains significant in the LA and LAA. I'm going to just skip down to their final comments. This study provides insight into the mechanistic role of obesity and MI in atrial remodeling. The authors state that they demonstrate that obesity independently of MI significantly increases atrial adipose tissue, and that furthermore, obesity also causes a higher level of intramyocardial adipocytes. The authors state that this combined evidence offers insight into how obesity mechanistically acts as a risk factor for AF by increasing the adipose tissue both in and around the heart. MI had no effect on atrial remodeling, only together with obesity prolonged the PR interval, pointing to a synergistic effect between obesity and MI, but the exact link between MI and AF remains elusive. The title of the next paper is A Framework for Developing Successful Academic Industry Partnerships for Cardiovascular Innovations by Dr. Stephanie Seltzer and colleagues. First key finding is that academic industry partnerships are essential for advancing cardiovascular innovation by combining clinical expertise and industry resources to identify unmet needs, develop new solutions, and streamline commercialization. Second, the shift in research funding from federal sources to industry collaborations has increased the importance of these academic industry partnerships, but outcomes remain inconsistent and ethical concerns persist owing to a lack of standardized frameworks. Third, a comprehensive framework centered on 5 core principles: strategic alignment, infrastructure investment, systematic assessment, graduated implementation, and robust ethical oversight is proposed to guide successful relationships, addressing issues such as partnership types, contracts, and common barriers such as intellectual property conflicts. And finally, effective governance structures and conflict management with academic industry partnerships foster trust and maximize mutual value, accelerating patient-centered innovation and benefiting academia, industry, and patient outcomes worldwide. The title of the next paper is Clinical Evaluation of a Spot Check ECG for the Diagnosis of Atrial Fibrillation by Dr. Cameron Lambert and colleagues. First key finding is that opportunistic screening using wearable spot check electrocardiogram devices has emerged as a means of early detection of atrial fibrillation, yet remains limited by concerns for accuracy and false positives. Second, current practice guidelines stipulate visual inspection of the ECG waveform by a qualified clinician to confirm the diagnosis prior to initiating pharmacologic stroke. Third, the W1 ECG demonstrates highly accurate automated AF detection, few noise classifications, and exceptional normal sinus rhythm detection to mitigate concerns over false positives. Finally, qualitative preservation of ECG waveform features by blinded manual adjudication supports the requisite physician overread required by recurrent clinical practice guidelines. Next up is a paper that is titled Self-Supervised Contrastive Learning Enables Robust Electrocardiogram-Based Cardiac Classification by Dr. Deekshith Dade and colleagues. First key finding that the authors provide is that self-supervised learning enables accurate electrocardiogram-based cardiac classification even when labeled clinical data are scarce. Models pre-trained on unlabeled ECGs achieve substantially higher performance than standard supervised models when trained with limited labeled data, supporting use in real-world settings where expert annotations are expensive or are unavailable. ECG representations learned from large unlabeled cohorts generalize across clinically distinct tasks. Pre-training on one cardiac phenotype, such as the left ventricular dysfunction, improved performance on a different biochemical outcome, which was serum potassium chloride abnormality, suggesting that contrastive learning captures broadly relevant cardiac signal features rather than task-specific patterns. Third, architectural inductive bias via lead grouping, in parentheses, LGT temporal net, end parentheses, consistently enhances performance, especially for the potassium chloride task, indicating that explicitly modeling interlead structure improves representation quality beyond standard temporal convolutional models. Finally, model adaptation to the target task remains important for clinical deployment. Although pre-trained models provided strong initial representations, fine-tuning on task-specific data yielded the highest performance, emphasizing the need for downstream calibration before clinical use. Up next is a paper that is titled Identifying Hidden Medical Complexity in Cardiovascular Care, a Large Language Model Approach to Evaluation and Management, Coding and Documentation by Dr. Victor Abrich and colleagues. First key finding is that an artificial intelligence-based application applying the 2024 Evaluation and Management, or E&M, framework to cardiology and electrophysiology notes matched previous coder adjudication in 70% of encounters, with 25% assigned higher EM levels and 5% assigned lower levels. Second, a key feature of the large language model was its ability to identify high-risk management considerations arising from interacting comorbid conditions or therapeutic limitations documented in the clinical note, which in some cases supported assignment of a higher EM level. And finally, these findings underscore interpretive variability in E&M coding under the 2024 guidelines and suggest a potential role for AI-assisted review in highlighting under-recognized management complexity in cardiovascular care documentation. The title of the next paper is the OPTIA-AF trial, a randomized study of rhythm-guided antithrombotic strategy after atrial fibrillation ablation in patients with prior drug-eluting stent implantation, by Dr. Dong-Hyuk Kim and colleagues. The first key finding is that the optimal post-ablation therapy for ischemic and arrhythmic risk in atrial fibrillation, or OPTIA-AF, is a randomized clinical trial evaluating a rhythm-guided antithrombotic strategy after atrial fibrillation ablation in patients with prior drug-eluting stent implantation. Second, the trial tests whether discontinuation of non-vitamin K antagonist oral anticoagulation with transition to single antiplatelet therapy is non-inferior to continued anticoagulation. 3, the study integrates durable sinus rhythm, residual coronary ischemic risk, and bleeding risk to individualize long-term antithrombotic therapy. And finally, the OPTIA-AF incorporates standardized rhythm surveillance and clinically meaningful composite endpoints, including myocardial infarction. So this is a design paper, and we look forward to the results of this study. Title of the next paper is Complex Signal Identification as a Marker of Left Atrial Remodeling and Very Early Recurrence After Atrial Fibrillation Ablation by Dr. Minoru Nodera and colleagues. First key finding is that complex signal identification, or CSI, detected widespread fractionated electrograms in the left atrium even in patients without low voltage areas. Second, a higher CSI burden was significantly associated with a slower global left atrial conduction velocity, as quantified by the local activation time velocity vector module. Third, very early recurrence after atrial fibrillation ablation occurred exclusively in patients with CSI-positive regions. And finally, CSI may be a potential marker of subtle left atrial electrical remodeling that is not captured by conventional voltage mapping. The next paper is Estimated Longevity of Contemporary Subcutaneous Implantable Cardioverter Defibrillators, Multicenter Real-World Data by Dr. Matteo Ziacchi and colleagues. First key finding is contemporary subcutaneous ICDs demonstrate an estimated median longevity of approximately 9 years in real-world clinical practice, exceeding manufacturer projections. The estimated SICD battery longevity is consistent over time. Third, telemetry-related energy consumption from remote monitoring and in-office interrogations has a negligible impact on overall device lifespan. Next, frequent shock energy is associated with a reduction in longevity, whereas most patients experience minimal battery depletion over time. And finally, the observed longevity of modern SICDs approaches that of contemporary transvenous ICDs, supporting their durability in routine practice. Next is a paper titled Utility of Impedance Mapping to Delineate Atrial Septal Occluders During Catheter Ablation by Dr. Keita Yoshiyama and colleagues. First key finding is that generator impedance mapping delineated a contiguous stable region corresponding to the atrial septal occluder footprint on electroanatomic maps. Second, bipolar voltage mapping over the occluder region was heterogeneous and did not reliably define device margins. Third, a consistent within-case impedance contrast, approximately 20 to 30 ohms, enabled practical demarcation of the device margin without a universal absolute threshold. And finally, impedance-defined contours may facilitate margin-oriented ablation, designed for lesion placement adjacent to a definitive no-ablation surface. The next paper is one of our Fellows Corner papers. This title is Pulsed Field Ablation for Atrial Fibrillation in a Patient with Core Triatriatum Sinister using a Single-Shot Mapping Integrated Catheter by Dr. Pantalaimon, Papakonstantinou, and colleagues. The key findings are first, that core triatriatum sinister presents unique challenges for transseptal access and catheter manipulation during atrial fibrillation ablation. Second, multimodality imaging, particularly transesophageal echocardiography, is essential when performing pulsed field ablation in complex atrial anatomy. Third, PFA can be safely and effectively performed in selected patients with congenital atrial abnormalities when procedural planning is meticulous. The next paper is also a Fellows paper. This is titled A Case of Post-Ablation Chest Pain Navigating the Diagnostic Dilemma by Dr. Jeanne E. and colleagues. The key findings are that 1. Post-cardiac injury syndrome is a clinically important cause of post-ablation chest pain and can mimic acute coronary syndrome. Second, the 2025 European Society of Cardiology diagnostic criteria facilitate recognition of pleural predominant inflammatory presentations. And third, early anti-inflammatory therapy with continuation of anticoagulation leads to excellent outcomes. Third Fellows case has the title Inferior Vena Cava Angiography through the Protective Sleeve for Right Heart Visualization in Helix Fixation Ventricular Leadless Pacemaker Implantation by Dr. Jeanne E. First key finding is that contrast injection through the protective sleeve of a helix fixation leadless pacemaker delivery system at the inferior vena cava level provides clear visualization of the inferior vena cava inflow, right atrial anatomy, tricuspid valve orientation, and right ventricular contour, offering comprehensive right heart anatomic guidance. Second, protective sleeve-based IVC angiography can be used as a primary imaging guidance during delivery catheter ablation, eliminating the need for a separate pigtail catheter and reducing procedural complexity. Finally, this technique supports safe and effective navigation during leadless pacemaker implantation across a range of anatomic scenarios, including unexpected catheter deviation and small or challenging cardiac chambers. The next paper is a point of view paper, and it is titled Proposed Workflow for the Prevention of Lead-Related Superior Vena Cava Syndrome, Dr. Fenna Daniels and colleagues. The first key finding is that superior vena cava syndrome is an uncommon but clinically significant complication of transvenous cardiac implantable electronic device leads and central venous catheters that pose challenges for treatment and future lead management. Second, the authors advise avoiding contralateral venous access in patients requiring additional CIED leads or central venous catheters to reduce the risk of superior vena cava syndrome. Instead, venous angiography should be performed to guide the implantation strategy. And third, the authors state that their structured clinical workflow enables tailored venous access strategies, thus minimizing the risk of lead-related superior vena cava syndrome. The title of the next paper, which is a research letter, is Cardiovascular Outcomes with Diltiazem versus Verapamil in Permanent Atrial Fibrillation by Dr. Lauren Fauchier and colleagues. Key findings: in a large real-world cohort of patients with permanent atrial fibrillation, diltiazem and verapamil were associated with distinct long-term clinical outcomes despite similar guideline indications. Second, after extensive propensity score matching, diltiazem was associated with fewer heart failure and cardiovascular hospitalizations compared with verapamil. Third, diltiazem showed less durable rate control with higher rates of tachycardia episodes, heart rates greater than 110 beats per minute, cardioversion, and atrioventricular node ablation. Third, stroke and thromboembolism were similar between treatment groups. And finally, the authors conclude that the findings suggest a trade-off between hemodynamic tolerance for diltiazem and durability of ventricular rate control with verapamil relevant to electrophysiology practice. The title of the next paper is Exploratory Assessment of Field Tag-Based Catheter Tissue Contact in Acute Lesion Surrogates During Pulsed Field Ablation by Dr. Hirata and colleagues. First key finding is the electroanatomic mapping-derived field tag feature correlated with acute low-voltage zones during pulmonary vein isolation and posterior wall isolation. Second, overlap of equal to or greater than 3 field tags best predicted adequate catheter tissue contact with an area under the curve of 0.85. Third, a 6 mm field tag radius most accurately reflected lesion boundaries with posterior wall floor overestimation. Next, crown-shaped catheter positioning produced broader low-voltage zones. And finally, field tag-guided workflows reduced fluoroscopy times by about 50% without an increase in major complications. Well, this ends the accepted papers, except for at the very end there is a letter to the editor and a response from the authors. I'd like to thank you very much for listening to the April podcast. We always welcome all listeners, and I'll look forward to talking with you again next month.